Okay, maybe we'll get started. Again, thanks to everybody for tuning in today. And I am Jamila Michener. Some of you may have known me. We've been at this for a while, but even if you don't, I'm a faculty member at Cornell, and I'm an associate professor of government and public policy and co-director of Cornell's Center for Health Equity. And I do a number of other things too, but I won't bore you with any more details about that. So now I have the distinct pleasure today. I've been really excited about this mic session, and I've been excited because we're going to be having a speaker that I think a lot of folks have been looking forward to. So Chima Dumele, Dr. Dumele, I hope I'm pronouncing that right. That's the way I pronounced it in my head for years, but Chima will correct me when he comes on if I'm wrong, is an associate professor of public health specializing in health policy at the Yale School of Public Health. His research has focused on the factors that influence how economically vulnerable populations access health resources. So work that is near and dear to my own heart, and this has included Medicaid. So part of what makes his work unique is how he places Medicaid services within a sort of larger ecology of related factors, such as other safety net programs, local policy environments, coverage features, and member social determinants. So today he joins us to share about recent work on interactions between Medicaid services and the SNAP program. I mean, I think this stuff is the best. And I hope it'll also give him an opportunity to share his broader reflections on this network of programs that we call the safety net. So please join me in welcoming Chima and his presentation today. And now you get to not hear from me anymore and to hear from someone who will drop knowledge.
Jamila, thank you so much. Good afternoon, everyone. It's so good to have a chance to be here with you guys and share with you today. Over the next 45 minutes or so, sorry, Jamila, over the next 40 or 45 minutes or so, I want to really kind of introduce you to a concept that I've been thinking a bit about. And kind of underlying it is the question of how we can build a safety net that respects the whole person orientation of individuals. I will also introduce a paper, but I really want to think about that paper as a window into the rest of the safety net and really consider it as a cautionary tale for what happens when we have an uncoordinated, really underconnected safety net. So I'm going to go ahead and share my slides now. There we go. Okay. Perfect. I want to, before I get started here, really acknowledge a fantastic team of collaborators here who allow me to present and take credit for their hard work from time to time. Hannah Factor, Anthony Lalo, and Jacob Wallace from Yale, and our colleague Matt Lavallee, who's now at Johns Hopkins. I also want to acknowledge, at least for the broader work here, the broader family of work that we have, generous funding from Robert Wood Johnson Foundation and the NIH, who supported this work. There are no other additional relevant disclosures. So those who know me know that I've been obsessed with this issue and this slide for a really long time. Just to orient you folks who haven't seen something like this before, this is the share of Connecticut budget that is spent on major priorities over the last decade or so, from 2010 to 2021. There are an endless number of take-homes that we can have from this slide, but I will focus you on just two. One, on your left-hand side, you'll see the increase in total healthcare spending. that includes Medicaid, the hospitals, CHIP, and the like, unless you think this is just a Connecticut issue. Nationally, total Medicaid spending has increased by about 60% between 2010 and 2020. And while it may not be as pronounced in the decade prior due to the expansion and the like, I'm sure you'll see similar numbers all around the country and in prior decades as well. The second point, however, I think is the truly operative and important point, that there is no free lunch, right? That an increase in healthcare spending is often kind of commensurate, with a decrease in welfare spending or stagnation in public safety or education or transportation or a host of other programs that are arguably more important for health than healthcare spending itself. So the fundamental question here is, given the kind of interconnectedness of the system, how do we approach cost control in the Medicaid and the broader safety net? Traditionally, many state Medicaid programs have thought about cost control in particularly kind of draconian ways, thinking about ways to reduce payments to providers or benefits to recipients, or even the number of people on the program. And while that may have kind of short-term positive effects on your budget lines, it clearly has kind of both short and long-term deleterious effects on health and the like. All right. The question that I've been kind of grappling with is, how much of this is us looking for our keys under the lamp, right, or under the street light, right? How often are we commonly and narrowly thinking about spending in Medicaid and the potential for cost savings in Medicaid only through the lens of health spending, right? Given the connectedness of these programs, does a smarter safety net require us to think about them jointly? The programs themselves aren't just connected. People are connected to these programs in ways that are important and interesting. So nearly 100 million people are engaged in the 10 largest safety net programs. And most people who are enrolled in one program aren't just enrolled in one program, right? A wonderful report from ASPE sometime earlier this year shows that 45% of Medicaid beneficiaries are enrolled in at least 2 more assistance programs. 90% of SNAP beneficiaries are enrolled in Medicaid as well, right? The vast majority of individuals are engaged in the kind of broader safety net in a way that suggests that the administration, the design, the way that we think about policy in these programs can impact people's lives, and that the policy in one program may have a cascading effect on the outcomes in another program. Beyond that, I think there is a growing consensus, and I suspect I don't have to convince anybody in this room, that unmet social needs and social determinants of health more broadly are important predictors and powerful predictors of health spending and health more broadly. But the question is, even if we presume that's true, how do we then take the programs that we have, the large public kind of government programs, and do we have a chance to both improve efficiency and promote health outcomes? All right. What are the options that we have in order to make the safety net both better for systems and better for individuals? So here are the large questions. I know we have a Q&A session later on, but here are the kind of large questions that I want us to grapple with broadly, even as we think about the specific example of the relationship between SNAP and Medicaid. The first question is, what are the consequences to the current system that we have? Right? Are there consequences to having a largely uncoordinated or siloed healthcare safety net? Second, is the juice worth the squeeze? Right? Are the benefits of a coordinated system worth the investments that are necessary to build one? And third, can we even do it? Is it feasible to design, administer services, and craft policy across adjacent safety net programs in a way that promote health? Lest you think this is just some large existential crisis, the reality is that the safety net has acute challenges as well, right? It's commonly under threat. In particular, a clear impediment to the kind of functioning and the ability to create a smarter safety net is the nature of it, the kind of pervasive nature of administrative burdens in the safety net, which leads to greater volatility and limits access to services. That is both a kind of long-standing problem and a continual one. These newspaper clippings are from the last few months, and they represent a sampling of concerns about new policies that would expand work requirement, the maximum age for work requirements from 49 to 54, potentially putting almost 1 million new beneficiaries, SNAP beneficiaries, benefits at risk. So one of the underlying questions that we're dealing with today is asking whether work requirements promote self-sufficiency, as they are purported to do, or do they contribute to administrative burdens that screen out vulnerable populations? Our assertion is that we can make progress on this both today through this presentation, but more broadly by linking data across safety net programs to help, again, engage and inform this whole person orientation as we are crafting policy. Today, we're going to primarily focus on this notion of screening effects, a question of who are the people that are impacted by these policies. So a little bit about our setting and providing some important context here. Our work today is going to use administrative claims data from the Connecticut Safety Net, in particular from the Connecticut Department of Social Services, which houses data for about 1 million residents of Connecticut residents. About 1 million of the 3.5 total residents in Connecticut are engaged with the Department of Social Services in some way annually. Within that, about 1 in 4 Connecticut residents are on Medicaid, and about 400,000 residents, including 40% of the Medicaid population, are on SNAP annually. So let me introduce you to what we're going to do in this paper. All right, we think this paper provides novel evidence on screening effects of the SNAP work requirements, and we get to examine those using really unique linked administrative data. So I will go into more detail into our approach, but very quickly, we use a triple difference model to examine the effect of SNAP work requirements using variation in exposure between towns and populations. And we have this really powerful linked individual level administrative data from individuals who are both in the Medicaid and the SNAP program that gives us information on program enrollment, demographics, benefit generosity, and health conditions. We hope to answer 3 clear questions today. The first question is, how do SNAP requirements impact the safety net participation? That is, both participation in the SNAP program and the Medicaid program when you think about them collectively and adjacently. Second, who gets screened out by SNAP work requirements? To what extent is this kind of a random process? And what happens when you account for people's health status when looking at who gets screened out? And then third, how long-lasting are any effects that we see? So for those of you who aren't going to make it to the end or may just stop caring at that point, I thought I'd give you a quick preview of our findings. So the first question, how do SNAP work requirements impact safety net participation? We find that when work requirements are implemented, we see about a 25% decrease in SNAP enrollment among the groups that are targeted. Conversely, and importantly, we see almost no change in Medicaid enrollment at the same time, right? I'll explain to you why I think that's so important later on. 2, who gets screened out by SNAP work requirements? It's who you might expect. even within the kind of vulnerable population that is the folks that use and experience the safety net, SNAP work requirements screen out older, sicker, and lower income populations. And really kind of importantly here, they also screen out people with nutrition sensitive conditions like diabetes. 3, how long lasting are these effects? We show that disenrollment effects persist for nearly 2 years. And that you can't really put the genie back in the bottle. All right. So we'll have a second experiment here where a number of these towns roll back their work requirements. And we show that that doesn't meaningfully reverse the trajectories between towns that rolled back work requirements and those where they remained in place. Okay. So as much as I'd like to lie to you, we're not the first people to think about this. Right. There's actually a growing and robust literature. And I think our study really contributes to 2 primary strands of literature here. The first is this notion of screening effects of administrative burdens, right? So Ben Summers and colleagues in Medicaid, others in the SNAP program have looked at the effects of these kind of work requirement type programs to assess how effective they are at both reaching their purported goal and whether they induce people to work. I will tell you that for the most part, people have found that there are no important kind of impactful effects as it relates to screening work requirement programs inducing populations to work. We're going to lean on those results a little bit here today. The second strand of literature that I think our work contributes to is this notion of cross-program offsets. That is how for people who are jointly enrolled in programs, policies or administration of services in one program impact the use of services in another program. I think there has been a wonderful amount of important and thoughtful research in this kind of growing and emerging area. I will say, however, that the findings here have been somewhat mixed and inconclusive, in part because it's a really difficult question to answer, right? For the most part, as people change eligibility status or enrollment status, it is often associated with a change in their underlying conditions or their underlying life circumstances in ways that make it hard to identify a causal effect for some of these questions. Therefore, I think our data and natural experiment really allow us to both build upon and extend this work to provide new insights. Specifically, we get to talk a little bit about the effect of cross-program effects of policies that impact administrative burdens. That is, taking the work on administrative burdens and thinking about them in a cross-programmatic way. 2, we get to understand or to conduct a comprehensive analysis to understand the populations that are most acutely targeted by these work requirements. 3, we get to understand the kind of lasting effects of both work requirements and any subsequent policy changes. And then 4, as I noted previously, the reality is that this is also relevant for ongoing and important kind of current policy debates as well. So what we're going to do for the rest of the talk here is introduce you to the experiment and the sample and the data that we're using to make these contributions, and then answer these 3 important questions. 1, or show you the data that responds to these 3 important questions. How do SNAP work requirements impact enrollment? Who gets screened out by work requirements? And how long-lasting are the effects? And then I will kick off a few questions that are kind of mulling around in my mind for a discussion, and I'm hopeful that we have a robust Q&A afterwards. So I told you that I think our data and our natural experiment allow us to kind of uniquely position us to answer some of these questions. So I'll tell you just a little bit about both. We have tremendously rich administrative data that has a linked masked ID that connects enrollee information across safety net programs. It has all of the kind of features of Medicaid data, Medicaid claims data, including enrollment, diagnosis on claims, and the like, that really allow us to understand the health status and the utilization of people that are impacted by SNAP work requirements. And then three, we have also very detailed data on the SNAP side that allow us to think about who, in terms of the people on the income spectrum, are impacted by work requirements. A little bit more about our setting. So in order to answer this question, we tried to find really the right experiment to do this. And the one that we found was the reintroduction of work requirements in January of 2016. So for a little bit of context, during the Great Recession, work requirements had been suspended. So they had been suspended from, I believe, 2009 to 2016, and they were just being re-implemented. However, they didn't apply to everyone. In general, they applied to towns based on their employment status. That is, places that had low enough employment rate were presumed to be ready to restart them, and other places could apply for a waiver. So we leveraged those different populations and those different towns in order to assess changes here. So the populations that were included were able-bodied adults without dependents between the ages of 18 and 49, exemptions for parents, caregivers, disabled populations, and or individuals with disabilities and others. And again, towns that had high enough employment rate or high enough unemployment rates may have been exempted a waiver. The way that the policy worked, that it provided a 3-month grace period. So despite the fact that the policy went into place in January of 2016, individuals weren't kicked off the program until April of 2016, presuming that they didn't show evidence of working the requisite number of hours that they needed to work. And our study population includes or a study sample includes the individuals who are eligible, who are in the Medicaid and SNAP program prior to work requirements, in the month prior to the administration of work requirements. Okay, I told you that we used a triple difference approach to study changes in enrollment. So many of you are familiar with the difference in differences approach. Here we start with that, right? So towns that had work requirements relative to towns that were exempt in the period before and after the implementation of work requirements. The third difference in this case is comparing enrollment among these able-bodied adults without dependents who were included in the policy relative to parents and caregivers who were excluded from the policy. If that wasn't overkill enough, we include a second identification strategy here to assess the robustness of our results, where we leverage the sharp cutoff. Again, this only applied to people between the ages of 18 and 49. So we leverage the sharp cutoff at age 50 to compare enrollment changes in enrollment between populations 40 to 49 who were close to the cutoff, but included, and folks aged 50 through 59 who are excluded from the policy. The last wrinkle here is that about a year after the implementation of the initial policy, half of the towns that were previously subject to work requirements decided to eliminate the work requirements, which allowed for a second experiment on both kind of long-run cohort effects and to understand the effects of rolling back a policy, essentially, as I noted, whether you can put the genie back in the bottle. Okay, just to make that a little bit more kind of visually comprehensible, here's what this looks like. So as in a standard kind of difference in differences approach, we use a pre-period from August 2015 through April of 2016, the 9-month period, and then we assess the changes in enrollment relative to the post period, which is April 2016, following the implementation of work requirements through December of 2016. In January 2017, we have the work requirements eliminated. I'll come back to that experiment in a second, but I wanted to orient you to the kind of first part of our policy approach here. Okay, so this is a map of Connecticut. For those of you who've never been here, it's a wonderful place. The towns shaded in blue are the towns that were included in work requirements, and the towns in gray are the towns that were exempted from work requirements. If you're looking at this like I would be looking at this, one of my first questions would be, are these towns fundamentally different, right? They appear to be clustered in a way that would concern me a bit. And you're correct. So there are some notable differences in the groups of people across that even among the group of SNAP and Medicaid recipients that reside in these towns, both in the able-bodied adults without dependents and the parents and caregivers. Therefore, we implemented a 1-to-1 propensity match strategy based on demographics, town, and whether you were enrolled in SNAP in the pre-period. And ultimately, we are able to get really tremendously comparable populations that allow us to have more confidence in our estimates not being driven by the differences in the people that are enrolled in the programs or that are affected by the policy. Okay. So back to the second experiment. 87 towns added work requirements, and I think it was 87 towns added work requirements in 2016. 41 of them removed or subsequently eliminated work requirements in 2017. This allows us to have a really long panel of data, and it does two things for us. One, we can examine the long run effects, and two, we can examine the subsequent effects of eliminating this policy. So we'll do both here today. Okay. So what do the results say? This is our first main result here. And what you'll see here is that on the left-hand side of the dotted red line in the middle, which is when work requirements were put into place and benefits were put at risk, a fairly stable enrollment of individuals in the SNAP program prior to work requirements. Following work requirements, the implementation of work requirements, we see an immediate and sustained 6 percentage point drop in SNAP enrollment among these individuals. This would correspond with about a 25% drop in the program enrollment among the targeted populations. I want us to think about this, however, in the context of Medicaid for a second, right? To the extent that the purported goal of SNAP work requirements is to get people not just working, but towards self-sufficiency, we find that on the right-hand side here, almost all of these individuals remained in the Medicaid program. So despite the precipitous drop in SNAP coverage, the vast majority of these individuals, almost all of these individuals over the same period, remained enrolled in Medicaid. Putting that in further context, if you're a state then thinking about the efficiency of your program, taking nutritional supports away from people for whom you're paying for the healthcare costs may not be the smartest approach. Moreover, we have, I think, what we would call further suggestive evidence that these policies, even if they were to induce people to work, don't induce people to work in meaningful enough ways to actually get them off of the safety net. Okay, this is just putting numbers to the graph that you just saw. As I mentioned, we have about a 6 percentage point change in the number of individuals enrolled in SNAP, or the proportion of individuals enrolled in SNAP, corresponding with about a 25% adjusted change. Similarly, we see almost no change in the proportion of individuals that are enrolled in Medicaid during the same time. As I mentioned previously, we used a second identification strategy, comparing individuals 40 to 49 who were affected by the policy relative to individuals 50 to 59 who were not affected by the policy. And we see a very, very similar story. As a matter of fact, we see a slightly steeper effect of 8 percentage points. However, it still corresponds with about a 25% decrease in program enrollment. Who gets screened out by work requirements? When we start looking at the both demographic, health status, and income-related conditions, income-related properties of the individuals who were impacted by these, we see a very interesting story. First, older individuals, 40 to 49, sorry, just to orient you, the blue line here is the average effect. While the gray line on the right would be a no effect. We see much larger effects for individuals who are older relative to younger populations. We see slightly larger effects, but not really meaningful for both male, non-Hispanic Black and Hispanic Black populations relative to female and white populations. In terms of chronic conditions, we see that as the number of chronic conditions increase, the effect of on enrollment also increases, right? Or to frame it slightly differently, individuals who are more vulnerable here, who are sicker, are more likely to get kicked off of the program and get screened out of the program by these work requirements. We see a similar story as it relates to income. That is, for individuals who have a net income of 0, that is, getting the maximum amount of benefits from the SNAP program, they are much more likely to get kicked off the program. But it's worth noting that even individuals who have very little income, which suspects that they might be, which indicates they may be working already, are also impacted by this policy, right? That in addition to the policy having the capacity to target individuals, it also has the capacity to increase administrative burdens for individuals who do comply. Similarly, we see among kind of nutrition-specific conditions, like diabetes, a pronounced effect. So, for example, for diabetics, we see an effect that's about 2 times the size of the average effect. Okay, just a really quick summary so far, and then we'll push towards the end here. SNAP work requirements reduce SNAP enrollment by about 6 percentage points, although we see slightly larger effects for older populations and other vulnerable groups. We see no effect on Medicaid enrollment, and it's worth keeping in mind here that the state continues to pay for the health spending of these individuals. Okay, how long-lasting are the effects? In this panel, we follow people for 24 months following the implementation of SNAP work requirements. And we find that at 18 months, the effect is significantly attenuated, but only at 21 months do we see no differential effects in terms of trends between individuals in towns that were subject to work requirements relative to individuals in towns that were exempted. Similarly, it's worth noting as it relates to the impending or ongoing policy that these results are again much worse for individuals who are 40 to 49, suspecting that the effects of the current policy may even be larger and more deleterious. Furthermore, many of these individuals, even in the 24-month period, don't have a trajectory that kind of catches up and corresponds with the with the towns that were exempted, right? There is a permanence to the effects of these policies. We see a similar long-run effect for individuals who are sicker in terms of the number of chronic conditions. Again, a similar effect for people that are most vulnerable in terms of receiving the highest number of benefits from the SNAP program itself. And again, a similar effect for individuals who have nutrition-sensitive conditions like diabetes. Okay. You should note here that I've tried to be fairly careful in how I talk about the kind of normalization of trends between individuals that were in towns that were affected by work requirements and individuals that were in towns that were exempted. Here in this slide, we actually look at the proportion of individuals who dropped off the program because of work requirements and come back. And we see that even at 24 months, only 25% of these individuals or so end up back in the program. The rest of the effect that we see is largely from an acceleration of attrition among people who would likely drop off from the program anyway. So they were probably going to drop off sometime in the next 2 years, but the SNAP work requirements significantly accelerate that process. Finally, I want to walk you through the results of this this last experiment here, where we again start with these towns that were exempted and not exempted from work requirements, exempted and subject to work requirements. And then we show that a substantial fraction of them, about half of them, rolled back work requirements or eliminated them a year later. In the light blue here, we have the towns that eliminated work requirements relative to the dark blue, which are the towns where they remained in place. 9 months after reversal, we find only a 1.2 percentage point difference in the effect of the towns that repealed work requirements or that reversed work requirements relative to the towns where they stayed in place. Framed differently, that is, there was very, very little effect of reversing these policies. As a matter of fact, once the policies start having negative effects, it's actually very difficult to reverse. They are largely irreversible. Okay, what does this mean? So we looked at the proportion or the amount of dollars per household, and then nationally that might be lost in benefits for SNAP recipients associated with work requirements. And what we find is that the average family would have lost about $2,750 per household. And if we were to assume that the same proportion of individuals were impacted, and they had the same proportion of individuals that were able-bodied with able-bodied adults without dependents in states across the U.S., that would correspond with about $372 million in lost benefits for SNAP recipients. Okay, there's some limitations here, as there are with any study, right? This is a single study in a single state using a single experiment. While we would actually like to go further and look at the effects of being dropped off the program on health outcomes and spending, in this particular study, we're probably underpowered to do that, but please stay tuned. We have some additional work coming out on that. And then third, while individuals are not directly identified as able-bodied adults without dependents in our SNAP data, they are identified as that in our Medicaid data, which largely mirrors the SNAP definition. Okay. In terms of the findings, what we find here today, I think the body of work that we've presented suggests that SNAP work requirements are both inefficient and ineffective. They don't actually kind of achieve their purported goal. And if you think about them in the context of Medicaid, it is tremendously inefficient to be taking nutritional benefits away from people for whom you're paying for their healthcare costs. 2, work requirements impact all groups negatively, but actually target the most vulnerable. That includes older individuals, individuals with more chronic conditions, or those without income are disproportionately screened out. But it's worth noting that even the people who are working and complying often get screened out as well, suggesting that there may be additional administrative burdens for those who are working. And the effects of bad policy are lasting and difficult to reverse. We find the effects persist for 21 months. We find that there's very little benefit in removing work requirements after they are in place, and they cost and lost benefit. The number of lost benefits for individuals and families are really staggering. What does this mean? Let's come back to the questions that we posed at the beginning. Right? What are the consequences of an uncoordinated safety net? Currently, we have a system that's actively working against itself. For example, Medicaid-specific investments like food as medicine are likely to be undermined if you are taking food or rather money for food away from your beneficiaries on the other end. Two, it might be worth rethinking our conception of what able-bodied looks like. Right? Our findings here suggest that there is a pretty strong relationship between poor health and capacity to work, which suggests that many of the individuals that are sick here are folks that we may want to take special care for as we roll out these kind of deleterious policies. Third, a smarter safety net may actually require that we reimagine our approach to policymaking. Typically, policymaking has been designed for average individuals. The reality, however, is that we have a robust data infrastructure that may allow for carving out specific groups that are going to be negatively impacted by the policy, particularly when those groups correspond with things that are going to be efficient or inefficient for health systems themselves. So I think that's all I have for you today. It's about 45 minutes in. I thank you for your time, and I look forward to your questions.
All right. Thank you so much, Chima. I'm excited to jump in, and I don't want to waste any time because we already have questions in the Q&A. So I'm just gonna begin. Well, first I'll say, hi, Joan. Oh, maybe, yeah, Joan made a comment first, just highlighting that these findings, I think, underscore what what a lot of folks who are in this space think about Medicaid work requirements, which is that they do harm. And even beyond the obvious harm of benefit loss, in terms of other goals and other populations that we want to support. But I don't think I've seen evidence like this on that score before. So I'll sort of add to what Joan said and say, this reinforces, I think, the kind of intuition of people who are spending a lot of time in this policy space, but I find it so valuable to have evidence to reinforce those intuitions. Otherwise, I think it's harder to make the case. But Joan also asked a question, which is related to that first slide, that one that you said you have sort of obsessed over for a long period of time. I always find that long-standing obsessions generate the best work. So I'm a big fan of long-standing obsessions. Joan asked if the slide on states' budget spending only includes the state share of Medicaid spending, and add some other detail to the question, but that's the general question.
No, I actually believe that it is the total outlays, right? So both the state and the kind of federal matched budget on healthcare spending. Now, it's again worth noting that this isn't just limited to Medicaid spending, but also spending in hospitals and the like. I believe that's correct, but I will tell you, Joan, it's a wonderful question, and nice to hear from you, Joan. I will tell you that I think the story would be the same either way, right? That this is spending that is going up in ways that are unsustainable and that are clearly crowding out some of our other priorities.
Yeah, that makes sense. Although I always like to think about these distinctions between what's happening with states and the federal government and some of the nuances that implies. We have a question about overall take-up in SNAP among the sort of eligible population, just in terms of who's taking up SNAP, who's not, and how, if at all, that matters in terms of how we interpret and understand the results, the findings that you just shared with us.
Oh, that's a really good question.
It is a good question.
It's a very good question. I will tell you that take up among this population is staggeringly low, right?
Wow.
So this is the kind of single or childless adults portion of Medicaid. Uh, our estimates suggest that somewhere between a take-up rate of somewhere between 20 to 30%,
Yeah.
right? Which is the amount of money that's left on the table, the amount of opportunity that's left on the table. And it's not just 20 to 30%, but we see what the rates are among individuals with clear need for it, like individuals with diabetes and the like. I don't think it dramatically impacts our findings, but as a general aside, uh, we're often just floored. I will tell you the way that I think it does kind of impact the interpretation of our findings. These are the individuals who really have jumped through the hoops in order to get through the program,
Mm.
right? This is the 20% of individuals that
Wow.
have, read and figured out what their magi income is and all types of things. It is particularly kind of disheartening to think about a program that is then kind of undercutting that group because selection would suggest that those are the people that really need it the most.
Yeah, I mean, I don't know if you had, it doesn't sound like you do, but I'd be really curious to see take up data sort of before and after. In other words, I wonder whether there's a deterrent effect to the work requirements. It's one thing to see a sort of decline in enrollment for people who have already jumped through the hoops, who are already inclined. But if there were sort of people who were on the fence, who might have otherwise taken up Medicaid, if the take up rates are adjusting, right, in relation to, anyway, no idea if there's data to figure that out, but the take-up question, which I thought was a good one, made me think about that as a sort of different outcome in terms of a similar kind of analysis.
I think we do have the data to do that, and I think it's a fantastic question.
Awesome. Well, I want to know when you find out.
Sure.
There's another question in the queue that I want to be, a couple other that I want to be sure to get to, but I'm gonna, if I may, take moderator's liberty and inject myself in the queue. One thing that really strikes me around the whole discussion about work requirements, especially in terms of SNAP, but more broadly in terms of Medicaid or TANF or what have you, is the kind of the idea that work requirements are sort of a racialized policy instrument, right? And I'm curious whether you are either able to, given your data, or whether you ever did, consider heterogeneity across racial subgroups, and what you think about that whole way of thinking about work requirements as a policy instrument.
Yeah, yeah. So we did. And you should, as I believe you know, that I fundamentally agree with you that these policies often are both kind of fundamentally targeted towards racial groups and the most vulnerable groups, but also are often a story about who knows how to navigate the system.
Yeah.
Right. And while we only found slightly increased rates of people kind of being impacted, uh, Black and Hispanic enrollees being impacted relative to white enrollees, given the kind of raw numbers of individuals on the program, this is impactful. This matters, and this has clear potential to dramatically kind of expand disparities.
Yeah.
There's no
Yeah.
doubt about it. Yeah.
Yeah. Okay. Well, there's at least, that's great. This is all really exciting. There's at least one more question that I want to try to squeeze in here. This is from an attendee who shall remain anonymous. Um, it's just about the kind of observation that there's a significant, even though smaller, decline in SNAP participation among parents and caregivers in cities with versus without work requirements. And the question is really about whether you see this as evidence of spillover effects of work requirements, even on individuals who shouldn't otherwise be affected.
Um, I think that is very much open to interpretation, but I think Jamila, what you were referencing a second ago is really a broader chilling effect that
Yeah.
these policies have, right? And I suspect that for individuals who may have less experience kind of navigating the system, it's hard to know the nuances of every policy and whether it applies to you and what you're supposed to be doing, and whether that means that that the program is no longer for you. Like, I don't know if we've thought deeply enough about this to suggest that this is actual evidence for spillover effects or chilling effects in the way that the question suggests. But it wouldn't surprise me at all, and it is consistent with what we've seen as it relates to many other policies, particularly policies that are implemented in the safety net.
Yeah. Okay, we can squeeze in one more, I think. It's never enough time. At least I think this in general, I think this especially with you, Chima. I feel like it's never enough time. But this one's from Will, and I think it's a good one. This study clearly involved a careful collaboration with the state to gain access to these data and to link them. Any advice or lessons learned for researchers seeking to engage in similar conversations or collaborators with policymakers in states? It's a broader kind of question that might be worth hearing the answer to from some folks.
Yeah, I think that's a great question, Will. I am always trying to find common ground, right? So rather than going to states and exclusively telling them about the things that you're interested in many ways, we tried to do two things. One, to find questions that were of national importance and local relevance in the things that they were already interested in. And then two, to figure out how to make sure that the results that we were going to kind of require were going to be actionable, right? We in many ways we have a unspoken understanding with our state that there are no mental gymnastics, right? We are engaging in work that can be translated into action. That fundamentally can change the way or improve the way that they deliver services, that they administer services, that they craft policy. So these aren't, wouldn't it be interesting type questions. These are questions that are very much intentionally designed to both improve people's lives, but improve the way that state officials can do their job and improve lives themselves.
Wow. What an inspiring note to end on in terms of, I think I will go out on not so far of a limb, and maybe not a surprising limb, to say, I think that's a model for how we can develop questions as researchers, how we can partner with state and other collaborators, and how we might think about the purposes of our research and what we're up to. So even though I want to keep asking questions, I'm going to end there because you left us such a kind of perfect and inspiring note to end on. I couldn't have planned that better if I were trying to. So just many, many, many thanks to you, Chima, for sharing this with us. I know I will be avidly waiting for like papers to cite and just to see this coming out, and also to share it with partners that I work with in states, and when I have opportunities to go before policymakers and so on and so forth. This is going to be so useful and so impactful. So thank you.
I'm glad that it's useful. Thank you so much, and everyone have a wonderful holiday season.
Thank you for joining us today. You'll be receiving a 2-question survey about this session. This really helps us to continue to make the program better. So please, if you can respond, we would be very, very grateful. And we're looking forward to seeing you at our next Mike session. It's going to be a treat. I think every one of these is a treat, but this one is as well. It's Wednesday, February 14th. What better thing do we all have to do on Valentine's Day? I'm not sure, but we will be featuring Kate McAvoy, the executive director of the National Association of Medicaid Directors. I find Kate always has insights. I expect this to be no different. You can see on the screen, the talk will be focused on the current state of Medicaid and applying learning from the pandemic, which is something I think many of us have been thinking through, grappling with. RSVPs are now open, and you can also see the lineup of speakers that we have for the first half of 2024. I think you'll find that we have some real policy-focused sessions coming up, so please make sure to stop by and join the Mike community. and look at our website for all the information you need about our next meeting in February and about some of our meetings going forward. The website is at www.medicaidinsightscolloquium.com. Thank you so much for being here today, everyone, and hopefully you have a peaceful and restful and warm season coming to you as we approach these holidays. Take care, everyone.